Okay, so let's talk about some sample drugs. Now, most of these drugs, no, you already have seen them from our previous discussions, no? Like for example, class, no, but let's just highlight a few, diba? Let's highlight a few, and then we can continue, no? So, wait, sa epinephrine and albuterol, no? These are the receptors that are affected, or they are the receptors that they will affect, no? Epinephrine is for the emergency treatment of anaphylaxis, albuterol is for the emergency treatment of asthma. Sila ito na-discuss sa tagsa, no? We have our ephedrine, hydrochloride, dopamine, phenylephrine, and pseudoephedrine. We've discussed this before, diba? This is for nasal congestion, your phenylephrine and pseudoephedrine. We have our dobutamine. This is to treat cardiac decompensation. Because remember, if you activate our beta-1, it will increase your contractility, di ba? Contractility, no? Agonist pa man di ba? Agonist, we are trying to mimic the effect of your SNS, no? Mimic the effect of your SNS, no? Tanawa, if we will discuss ato tagsa og discuss, no? If our ephedrine, our B1, remember, if you activate B1, it will increase your BP. That is good for your hypotension, di ba? It will also bronchodilate, no? Bronchodilate, which is for bronchospasms, di ba? No? So, mo na siya, B1 is to increase, no? Asa mo to kung kuan. B1 is to, increase BP. This is good for hypotension, di ba? Alpha and beta receptors, remember kung musaka ta diri sa atong alpha receptors class, no? If we go up, no, remember, if you stimulate the SNS, then it will decrease fluids, di ba? It will decrease fluids, no? So this is very good for nasal congestion, because remember, nasal congestion is just an increase in fluids, no, in your nasal cavity. And another thing you need to consider is, remember, the main reason as to why there is nasal congestion is because there is vasodilation of blood vessels, no? Vasodilation. So our alpha 1 and alpha receptors, if you trigger them, they will cause, remember, vasoconstriction. Diba? Yan na siya, class, no? Beta 2, remember, it will bronchodilate, no? So it will treat bronchospasms, diba? It's like that, no? It's quite simple, no? So let's talk about some specific drugs that we need to discuss, no? So epinephrine, okay? This is administered SQ and IV or via inhalation. Class, but lagyan mo yan ng malaking sara, never PO, never orally. Okay? Nga naman, because rapid metabolism in GI tract, decreased bioavailability. Okay, so dili pwede sa atong kuan. Okay? This is a very potent inotropic agent. Okay, so this will increase contractions, no? This will increase contractility. So you need to, because of that, there will be an increase in heart rate and BP. Increase in heart rate and BP. So dapat ka mag-ECG monitoring. Okay, ECG monitoring, no? This is used for the rapid treatment of anaphylaxis. When we say anaphylaxis, okay, this is the sudden closure of airways due to allergy. Okay, sudden closure of airways due to, and remember, class, airway is a big problem, no? Because if your airway is closed, there's no oxygen anymore. So anaphylaxis is an emergency case, meaning to say you must be very fast, no? Epinephrine. Okay, dapat tagaan din ani mo epinephrine if the patient has anaphylaxis. Now, what are the signs and symptoms that you can see nga na ay emergency closure, no? Now, the first thing that you will see is there is wheezing that progresses into no lung sounds. Okay? Lung sounds. At first, it will be wheezing, and then when it fully closes, wala na yung lung sounds. Di ba? Another thing that you might also consider is dyspnea. Okay? Dyspnea. No? So you also need to monitor urine output when giving this drug, because this can decrease, no? Because this is, remember, this will this is epinephrine. Epinephrine is an SNS agent. It will open the airways, but it will constrict the blood vessels. It will cause vasoconstriction of renal blood vessels. Okay? Which will in turn decrease renal perfusion. Gamay ra og dugo ang matos imong kidneys, and then it will decrease urine output, no? Do not give with TCAs. When we say TCAs, these are tricyclic antidepressants. Depressants and MAOIs, no? Your monoamine oxidase inhibitors. Nga naman, do not give, no? Because this can intensify effects of epinephrine. Okay, this can intensify the effects of epinephrine. Remember, if you block the MAO, no, it will prolong the effect of epinephrine, di ba? Epinephrine can also be used for cardiac resuscitation. When we say cardiac resuscitation, class, if the patient has flatlined, no? When flatline, class, we call that asystole, no? If the patient has flatlined, then we can give epinephrine. Because epinephrine, remember, look, it is a positive, or it is a potent inotropic agent, so they will increase contractility. Now, the most common preparation for emergency epinephrine is through your EpiPen. Kinesia, epinephrine pen, EpiPen. Now, if the patient is having lots of allergies, let's say dagan kasi like allergies, no? If the patient has lots of allergies, then this drug must be available at all times. Must be available at all times, okay? And must be stored in a cool, dark place. However, it should not be the fridge, okay? Not be the fridge. So, pwede ra sa cabinet, okay? Now, this is taken for, as I mentioned before, anaphylaxis, no? Lagyan mo yan ng malaking star, emergency drug for anaphylaxis, no? This is administered subcutaneously. Okay, listen to me, ha? Subcutaneously. If the patient exhibits the following, okay? If they are suddenly dyspneic, as I mentioned before, suddenly dyspneic, kalitang og kalang maglisod sila ginhawa, no? If they are suddenly dyspneic after exposure to an allergen, or if they have wheezing, okay? Or kini pa napailagan signs and symptoms of anaphylaxis, if they have itchiness or hives, or they have swelling of lips. If any of these occur after exposure to an allergen, then you must give epinephrine or EpiPen. Okay, so yung na siya gnaong, class, no? Another thing you need to note, ibalagyan mo yan ng malaking star, class, no? Inspect prior to administration. Okay? Inspect prior to administration. Okay? The first thing that you should do is your particles must not be pink or brown. Yan naman na siya, class. Namo na siya kuan. There is a small window somewhere in the packaging wherein you can see the inside, no, the fluid inside. If dapat gyud ang particles na nasa sulat, it should not be pink or brown, because if this is pink or brown, it means to say it's either expired or contaminated. So don't give if the particles are kuan. Okay? During administer, you administer on outer thigh. Okay, thigh part, no? Then massage for 10 minutes to improve absorption. Okay, massage for 10 minutes to improve absorption. So, ano siya? Epinephrine pen. I want to highlight ha, this is for anaphylaxis, no? This is the emergency drug. Okay? Drug of choice for emergency anaphylaxis. Ayan, no? Anaphylaxis, no? Next is our albuterol sulfate, no? This is a selective beta-2 adrenergic agonist, meaning to say they will only activate beta-2. Okay? This is used for emergency management of asthma. Okay? Now, lahi po di siya ha. Asthma class, no? Similar to your anaphylaxis, will also close your airways. Okay? So, same po siya sign symptom class. They will be wheezing, no? Which will progress to no sounds. There will be dyspnea, no? Ang difference sa asthma o anaphylaxis, no, is that asthma, no, it is a chronic obstructive pulmonary disease, no? Asthma can be triggered by other things, no? It can be triggered by not only allergens, no, but it can be triggered by any other things, no? Whereas ang anaphylaxis class triggered by allergens, triggered by allergy. No? The common side effects include your tremors and nervousness. Okay? Tremors and nervousness. Now, if the side effects occur, class, no, please report to MD. Okay? It means to say, class, that there is a possibility for an overdosage. No? So, report lang. Okay? Monitor if given with MAWIS. Okay? Because if you are given with MAWIS, this can cause hypertensive crisis. Lagyan mo yan ng malaking star class. Hypertensive crisis class mo to siyang katong SBP is greater than 180 mmHg. Diba? No? Greater than or equal to 180 mmHg. The thing about albuterol is usually this is given via MDI, okay, or metered dose inhaler. Okay, inhaler siya, no? I know you've seen an inhaler before, diba? Okay, so next is our clonidine and methyldopa. Now these are centrally acting. Ato isuwat dire. Ako itaasa pa. These are centrally acting. Okay, ayan, centrally acting alpha agonist, no? Centrally acting. Our clonidine class, this is an alpha 2 selective, and this is used to treat hypertension. Diba? Hypertension. Nga naman, sir, nga no hypertension man ni sir. Okay? Remember, I want you to remember, ha? Remember, alpha 2, okay? Alpha 2 will decrease epinephrine. Okay? And if there is decrease in epinephrine class, there will be vasodilation. Because there is vasodilation class, there will be a decrease in BP. Also, if you look at it here, no, mura siya bali. It is it has the opposite effect. No, it is the opposite effect. Kung alpha 1, it will increase blood pressure. The alpha 2 will decrease blood pressure. So keep that in mind, ha? Our clonidine is a alpha 2 selective, no? We also have our methyl dopa. This is a non-selective alpha agonist. Okay, this is a non-selective. Okay? Now, yung mga non-selective, no, it triggers both alpha 1 and alpha 2. Now, that's technically what happens, no? But listen to me, okay? Methyl dopa, once it enters the body, listen to me ha, enters the body, it is then converted. Akubot nga og taas nga line class, kana. Converted into, I will put it in yellow, okay? Methyl norepinephrine. Methyl norepinephrine. Now, kining ato methyl norepinephrine, this is alpha 2 selective. Ha, listen ha. Technically, methyl dopa is non-selective, but once it enters the body, it is converted into methyl norepinephrine. Now, remember, since this is alpha 2, this will decrease epinephrine and norepinephrine, di ba? And norepinephrine. In turn, class, that will cause vasodilation. And in turn, that will decrease BP. So, this drug can also be used, no? This drug can also be used, no? To treat hypertension. Ayan. This can also be used to treat hypertension. Although, daghan pa na siya og line effects. Daghan pa na siya line effects, no? Sige lang. What are the side effects of our adrenergic agonist, no? As I mentioned before, this is a result of non-selectivity or increased dose. Okay, when we say non-selectivity class, it's very similar to what I mentioned before. Because a certain drug does not, the certain drug, no, triggers a lot of receptors, oftentimes, no, the effects of the other receptors will become the side effects, no? So the thing about our adrenergic agonists is these are all reportable side effects, okay? These are all reportable side effects. Inyo gina siya i-report, okay? Because mostly it is due to the increase in dose, okay? Now, what do you need to do? No, what you need to do? Hypertension, tachycardia, and palpitations. For this, no, typically you need to monitor via ECG, di ba? You need to monitor, no, typically via ECG. For restlessness, you just give the patient time to rest, no? So you just allow them to rest. For dysrhythmias, mo gyapon class ECG. For urinary retention, remember, your SNS effect will decrease, no? It will decrease urine output because your SNS will relax the bladder, no? So what you need to do is you just need to monitor urine output. Okay? And then for pulmonary edema, how does this happen? No? Remember, class, the SNS effect will cause what? An SNS effect will cause ano pulmonary edema man? Kuya na siya, no? It's pulmonary edema. Not peripheral edema, but pulmonary edema. Ano man? It's like this. Okay? Remember, in your SNS, no, there is vasoconstriction. Okay? Now, typically, when we say edema, no, it's caused by dilation, no? But for our pulmonary edema, it's quite different. Let's see. Mao ni siya ang kuan class. Let's say for example, this is the blood vessel. Okay? And this is your alveoli. Na ha? That is your alveoli, no? Now, if the kuan class, the blood vessel is, if the pulmonary artery, mo ni siya itong gitawag na pulmonary artery. Artery. Okay, listen to me ha. If the pulmonary artery is constricted like that, no? Then there will be a lot of pressure against the blood vessel walls. Okay? There will be a lot of pressure against the blood vessel walls. Now, kini siya class, we call this type of pressure your PCWP. Okay? Also known as your pulmonary capillary wedge pressure. Okay? Now, since the blood is pushing against the blood vessel walls, the tendency of the blood is the blood will escape, no? Mugawas, no? The blood will escape and it will enter your interstitial space. Mo na siya class ang atong pulmonary edema because there is an increase in PCWP or your pulmonary capillary wedge pressure. No? So, nga na siya class, no? That's why there is pulmonary edema. So what do we need to consider? For epinephrine, you need to administer 1 mg. For cardiac resuscitation, I am gonna put a star on this. Ako ni siya gipalahi ha. Okay, typically an epinephrine is an emergency drug if there is a need for cardiac resuscitation. If ang imong patient kay nag-flatline na, your patient is flatlining or systole, then you will give epinephrine. Okay? In adrenaline form, no? Now, ay mo ihatagan na class 1 milligram like good. Okay, 1 milligram. Typically, you are gonna give 1 milligram every 5 to 10 minutes depending on the doctor during the emergency, no? Now, 1 milligram, if you look at this, no, 1 milligram is equal to 1 ml. 1 milligram is equal to 1 ml. So, when you are gonna prepare a syringe, listen to me ha, the first ml, okay, kini siya diri, the first ml class, that is your epinephrine. Epinephrine. While the next, listen to me ha, the next 9 ml, no, the next 9 ml, ani, ay bati ay, ako na lang drawing og tarong. The next 9 ml class, ayan. This will be PNSS. Okay? Nga naman, no? Class, epinephrine is very, very, class, very, very strong, no? When I say strong, it's very irritating against the blood vessels, no? So, this must be, okay, must be diluted with 9 cc PNSS or other diluents. Sometimes class, ang diluent nilang i-appeal is sterile water, no? Sterile water, but most often than not, it is PNSS, no? So, yan na siya class. 1 ml of epinephrine and then the rest is PNSS. Then, mo na i-mix, no? Dapat paspas ka na class, ha? You must remember that, ha? Remember that. Ay, dyan nagkalimot. Class, nga numan, okay? Because this is highly concentrated, no? This is very concentrated. Dapat dilita nga ha, if you give epinephrine during an emergency, dapat 10 cc syringe gina. 9 cc must be PNSS, 1 cc must be epinephrine. Dili pwede class nga mohatag kag 3 cc syringe, 1 cc ang imo epinephrine. No, dapat ngani gid. Okay? Typically administered over 1 minute. Okay, so slow ang imong administration. However, class, if emergency, then give rapidly. Pas give. No. Give rapidly. Okay? Especially, sabi pasabot ni mo na emergency, sir, especially if ka na cardiac arrest. There is cardiac arrest. No? There's a need for resuscitation. No? So, kana, epinephrine. So what else do we need to consider? You need to monitor the vital signs, no? If you are giving these drugs via IV, then you need to check every 5 minutes for the first 15 minutes. Every 5 minutes for the first 15 minutes. Okay? Especially BP and heart rate. Okay? Especially if BP and heart rate. Now, here is the keyword, ha? Report to MD if increasing. Oh, increasing, present. What I mean by that is this. If I gave the drug at 8 a.m., di ba remember I have to check every 5 minutes. Ako i-check 8:05 a.m., okay, 8:10 a.m., and then 8:15 a.m. Let's say ang iyang BP, o iyang heart rate pag 8 is around 86. At 8:05, it is, let's say, 107. At 8:10, let's say, 138. At 8:15, 100, let's say, 71. No? As you can see, class, it is increasing. Nagsigig saka ang iyang heart rate. So, if that is the case, you must report it. You must report it. Touch an ECG because, as I mentioned before, there are possible dysrhythmias. Okay? And then some of these drugs can increase the patient's blood glucose, so you need to monitor the blood glucose levels. No? Platoy normal nga blood glucose levels 80 to 100 milligrams per deciliter. Okay? Ano siya, no? Ano siya normal. Ayan. Wait sa. It's not over, no? Next is our adrenergic blockers or sympatholytics, no? There are two types. We have our alpha adrenergic blockers. Balik-balik lang tayo kasi, and our beta adrenergic blockers, no? Alpha blockers and beta blockers, no? So what do they do? Ato ibutang diri class, nagbalik-balik na lang kita ng mga drugs class, no? They block the effect of the SNS. Okay, listen to me, ha. They block the effect of the SNS. Remember, if you block the effect of an SNS, then what you will get is a PNS effect. Di ba? Kaya obviously, gi-block nimo ang SNS. And as I mentioned before, if you block one, the other will activate, no? So you will get a PNS effect. Okay? Now, how do they do this, no? There are two ways in which they do this, no? They will either occupy receptors, okay, or inhibit the release of neurotransmitters. So same class, diba? This is direct and this one is indirect. Okay? What I mean by that is, if this is the, let's say for example, no, the neural end, the end point of the neuron, and this is the receptor, okay? This is the receptor, no? Cannot. Let's say this is a beta 1 receptor, okay? And let's say this is norepinephrine. Now, norepinephrine wants to go to the receptor. Diba? Norepinephrine wants to go to the receptor. Now, let's say, for example, class, natay beta blocker. Kini. No? Ato ito beta blocker. What it does, class, is instead of the epinephrine or the norepinephrine entering the receptor, no? The beta blocker will sometimes go there first. Unhan niya, class. Okay? And because it is already there, no? Because it is already there, you know, let's say, duha ka buok, let's say, daghan. No? Daghan man ang beta blockers, no? Basig ma-misinterpret ninyo, ana. Let's say, daghan, no? Because of that, no? Our norepinephrine can no longer, they cannot enter anymore the receptor. And because of that, no? The SNS response is blocked. Diba? Kaya naman, wala man kasud, the epinephrine or the norepinephrine cannot enter the receptor. And because it is blocked class, it will cause a PNS effect. Ayan. PNS effect yan. Ano? It can also inhibit the release of neurotransmitters. So some beta blockers will stop, no? They will stop they will stop the neurotransmitters from exiting, no? They will stop the neurotransmitters from exiting the nerves themselves or the neurons, diba? So it's like that, no? Parang ganyan lang. Now, there are two types, no? As I mentioned before, alpha adrenergic blockers and beta adrenergic blockers, no? But there are two types of alpha adrenergic blockers. Okay, listen to me, ha? I will write this in black, no? There are two types. The first one is your selective alpha 1. Alpha 1 na siya, alpha 1 blockers. And then we also have our non-selective alpha blockers. Non-selective alpha blockers. Now, remember class, okay? Selective alpha 1 will only block alpha 1 receptors. When we say non-selective, they will block both alpha 1 and alpha 2. Now, listen to me, tanawa ha. If I block, balik kita ka ni class, if I block the alpha 1 receptor, what happens is instead of vasoconstriction, it will be vasodilation. Okay? Instead of increasing blood pressure, it will decrease blood pressure. It will decrease contractility. Diba? Okay? Instead of causing dilation, it will cause constriction. Okay? It will cause constriction of the pupils, or also known as meiosis. No? Also known as your meiosis. It will constrict, or it will contract the bladder. And remember, if you contract the bladder, the urine will come out, so there will be an increase in urine output. The prostate class will relax. Okay? Now listen, ang prostate mong class is like this. If it is your urethra, no? Sa mga lalaki, urethra, the prostate is around the urethra. Mura na siya, it's around the urethra. Now, if it is contracted, no? Iyan na piiton. It will constrict the urethra. And therefore, there will be a decrease in urine output. Okay? However, if it is relaxed, no? It will open up, no? It will open up the what we call the urethra, and it will allow urine to flow. So it will increase urine output. Diba? So mo na siyang effect class, relaxation. Okay? So that's what happens when you block the alpha 1. If you block the alpha 2, okay, if you block the alpha 2, the blood vessels, no, they will not, instead of decreasing the blood pressure, it will increase blood pressure. Okay, because there will be an increase in epinephrine, and it will increase GI motility and tone. So there will be increased GI motility and tone. So there will be an increase in stool production. Kalibang. Okay? Now look at all those effects. Look at all of those effects. Okay? Those are the effects of the PNS. Diba? Those are the effects of the PNS. Tanawa, increased ang imong GU. Increased ang imong GI. Your GI tract is increased. But everything else is decreased. Diba? So, parang magic lang. Diba? Parang magic lang, no? Now, here are the example drugs for our alpha blockers. Okay? You already know most of this, no? Phentolamine mesylate. This is the antidote for dopamine, epinephrine, and norepinephrine. They are for infiltration. They are alpha 1 selective. Doxazosine, prazosin, and terrazosine, they are also alpha 1 selective. They are used to treat hypertension, because remember, if you block alpha 1, it will decrease blood pressure. So this is very good for hypertension, diba? Also BPH, no? Benign prostatic hyperplasia. Okay? Ang imong prostate class, it is enlarged. Okay? But if you give them an alpha-1 receptors, it will cause the prostate to relax. And when your prostate is relaxed, no, as I mentioned before, it will not constrict the urethra. Dili niya piton imong urethra, no? We also have our phenoxybenzamine, and our phentolamine. Okay, this is used to treat pheochromocytoma. This is non-selective. Okay, as I've already discussed this before in our previous topic, no? Okay, so what do we need to consider now? This can decrease LDL and increase HDL, these types of drugs. So this is very good. This is a good effect, as I mentioned before. This is the same slides as before. Now, this is a good effect. This is safe for patients with DGDM because these drugs do not affect glycogenolysis. Nga naman, glycogenolysis is usually an effect of the beta receptors, no? So not alpha. That's why they are good for patients with DM. This can cause sodium and water retention. And the reason why there is sodium and water retention, class, is because of the koan, class. It is mostly due to what we call it is mostly due to koan, class, the vasodilation, which causes increased perfusion to the kidneys. Increased perfusion to the kidneys. Ayan. Okay? So, you need to monitor urine output. It's usually normally around 30 ml to 1 per hour. Sakto. And weight, no? And it should be given with diuretics, no? Should be given with diuretics, no? So, parang ganyan, di ba? Water retention. Next is our beta-adrenergic blockers, no? Koan, okay? Beta-adrenergic blockers. We already know this. Balik-balik tani class, no? Itong mga beta blockers, no? There are 3 types of beta blockers, as you already know. There are 3 types. Okay, we have our beta-1 selective. Usually these are for the heart. We have our B2 selective. This one is usually for the lungs. And this our non-selective. Okay, so both B1 and B2. Okay? Okay. So, what happens, mga good class, is if you block the beta-1 receptors, no, it will instead, no, decrease heart contraction, which will decrease heart rate. Decrease heart rate, okay? The kidneys will decrease renin secretion, decrease angiotensin, and decrease ang silang tanan, no? And because of that, there will be a decrease in BP, no? Wala. Uy. Words. No? Ay, kawa man. Okay, balik ta. Nakadurigon. So, decreased, and then there will be a decrease in heart rate, diba? Decreased in heart rate, no? There will be a decrease in renin, decrease in angiotensin, and there will be a decrease in BP, no? So, decreased heart rate and decrease in BP. That is the effect of your blocking your beta-1 receptor, no? If you block the beta-2 receptor, no, it will instead, no, increase GI motility, diba? So it in turn will increase stool formation. It will cause, instead of bronchodilation, bronchoconstriction. Okay? It will constrict the muscles of the uterus. Constrict or contract the muscles of the uterus, no? And it will stop the activation of glycogenolysis, which will decrease blood sugar. No, decrease blood sugar. So that is what happens if you block beta-2. As you can see, most of these are effects of, as I mentioned before, the PNS. Nagbaylo ra sila effect, di ba? Nagbaylo ra sila effect, no? Increased GU. Okay? Increased GU, no? Decreased everything else. Diba? Decrease everything else, no? Decrease, no? So, yan na siya, class. The effects are quite, just as I mentioned before, dapat master lang to ninyo atong initial table, no? So what are examples of beta-adrenergic blockers? We have our carvedilol. Kibaw na ta ni class, ito mga ulol-ulol, no? So carvedilol, labetalol, and propranolol, these are our non-selective. B1, they affect both B1 and B2. Okay, this is used to treat hypertension and heart failure, angina, and dysrhythmias depending on the drug. We have our metoprolol. No, metoprolol and acetabulol, these are both B1 only. Okay, so they are used to treat and manage hypertension. We have our betaxolol and our timolol. No, they are B1 and B2 only. They are the reason I'm putting this here is because they are for glaucoma. Okay, ang kini magong glaucoma, class. Okay, when we say glaucoma, there is an increase in intraocular pressure. So what we want is we want to decrease the IOP. We want to decrease the IOP. Now both of these drugs, will decrease IOP. How do they decrease IOP? No? IOP, class, no, is greatly tied to your blood pressure. So if your blood pressure is decreased, your IOP or intraocular pressure is also decreased. Ayan, partner na sila. These two, mga good class, they have very weak effects. That's why they are very good for the eyes. No? So what are the side effects? Dizziness. Balik-balik na tayo ni class, no? So fall safety. Diba? Fall safety. No? Hypoglycemic symptoms. So we need to monitor blood glucose. Ngano hypoglycemic man, sir? Hypoglycemic. Remember, if you block the beta-2 receptor, there will be no activation of glycogenolysis, which will decrease blood sugar, di ba? It will not activate or glycogenolysis, no? And sexual dysfunction, that's because of the constriction of the uterine smooth muscle, no? So it's also because of the decrease in blood pressure towards the penis. Now, so as I mentioned before, just tell the patient that this is normal. Now, this is normal, and disclosure is advised. No, is advised. Meaning to say, you have to tell the patient that this is a normal side effect. Okay. So nursing considerations for beta blockers: monitor the patient's BP before, during, and after. This is contraindications in patients with asthma. Specifically, class, ang atong non-selective, okay? Non-selective. Lagyan mo yan ng malaking star, okay? If it is beta-1 selective beta blocker, then you can give that drug because it does not affect the lungs. Okay? However, class, if it is non-selective, if it blocks both beta-1 and beta-2, remember, it can cause bronchoconstriction. No? And bronchoconstriction, class, is what happens already in asthma. You don't want to further constrict the bronchioles, di ba? Hold the drug if the patient's heart rate is less than 60. Beta blockers can hide the effects of low blood sugar or hypoglycemia. That's why it's very important, class, to monitor blood glucose, no? Monitor blood glucose, yun. Blood glucose. Okay, lagyan mo yan ng malaking star. Usually administered with a diuretic for hypertension. So, kabalik-balik naman tayo ni class, no? What diuretic, class? Usually, we are gonna use our thiazide diuretics. And do not discontinue abruptly because this can lead to rebound. No, rebound hypertension. So, to summarize, class, no, most of the drugs that we have discussed today, we've already discussed before. Okay? What I want to emphasize today, the difference between our discussion before and right now, is that you need to consider the effects to other systems. Because before, we were talking about, no, the effects of these receptors, alpha and beta, towards your heart, lungs, and blood vessels. Moro to siya. But right now, no, naana siya mga liver, uterus, no? And what I'm telling you here, basically, is I want you to master this one. Kini siya nga table, this one, no? Because if you know the drug classification, if you know the drug, Let's say, for example, the drug is a beta blocker, meaning to say it will block the beta receptors. So you're blocking sympathetic effect. If you block the sympathetic effect, then you will get a parasympathetic effect. And in turn, no, when you give a beta blocker, mao ni siya ang effects. Mao ni siya ang effects, di ba? These are the effects, no? It is a parasympathetic effect, no? So the heart rate will slow down, the blood vessels, no, asam to sa blood vessels, no, haridapit ito, PNS. The blood vessels will vasodilate, no? So it will decrease BP. That's why our beta blockers are used for hypertension, because beta blockers will decrease BP, no? So it's like that, no? You just need to master, especially our comparison table dyan. I'm highly emphasizing that you need to master this so that you will understand. Okay? If you have any questions, no, just message me. The thing is, we will be discussing cholinergic receptors the next time I will send you a discussion. Keep in mind, cholinergic is very, very complicated compared to adrenergic. Mas libog ito siya class, no? So, please study in advance.